Hello, everyone. Welcome to the first of two video lectures on coding and reimbursement. This first video lecture is captured in chapter one of your text. It starts right around the point of where we talk about principal diagnosis, UHDDS reporting, and so on. So let's have a look at prospective payment systems and how they use ICD-10 CM codes. And again, this is primarily what we're going to be focusing on. It's in the last set of bullet points. We're going to learn the importance about hospital inpatient prospective payment systems, otherwise known as DRGs, or more specifically now, MSDRGs, Medicare review programs, recovery audit contractors, and coding for medical necessity. And again, Medicare hospital inpatient systems for acute care hospitals such as Peace Health Riverbend are based on Medicare severity diagnosis related groups, right? We've had diagnosis related groups since the 1980s. The Medicare severity gives us a three-tiered system within each DRG. MSDRGs are defined by the ICD-10 CM and PCS codes, right? And we only have one MSDRG that's assigned to each acute care hospital. They're not cumulative. You can have more than one diagnosis code, but you can only have one principal diagnosis. Therefore, you can only have one MSDRG per hospitalization. And again, there, as we talked about, the MS or Medicare severity added three levels within each diagnosis related group. There are those with a major complication or comorbidity, the MCC, right, which reflects the highest level of severity within each DRG. And then we can have a complication of comorbidity that's kind of like mid-level, that's a little bit more resource intensive. And then we can have an MSDRG with no complication or comorbidity that affects the severity of illness or resource use for the hospitalization. Please review tables 1.1, 1.2, and 1.3 in your text to compare the MSDRG, the principal diagnosis, and the secondary diagnosis that is an MCC or CC that will influence the MSDRG assignment. And again, the MSDRG is built on the diagnosis and procedures that are coded by the coders. We can have one principal diagnosis and up to 24 additional diagnosis codes for a total of 25. Surgeries and other significant procedures can also add up to 25 procedures. Then the other thing we need to capture is the discharge status and whether the secondary diagnoses are considered an MCC or a CC. And you'll see that with the 3M encoder project that we have for you. And again, MSDRGs you can think of as groupings of diseases, right? And so we have a basic payment calculation. Each MSDRG, if you will, has a relative weight. Each hospital has an individual payment rate, and the hospital payment's determined by the formula. It's the MSDRG relative weight times the hospital base rate will equal the hospital payment. And Medicare will give additional payments to the MSDRG in certain situations. This would include disappropriate share hospitals, hospitals with house staff, in other words, residents, interns, fellows, get additional payment as the indirect medical education adjustment. There are additional adjustments for new technologies and medical services. There's discharge disposition, and there's certain outlier payments that are also allowed. But the vast majority of the revenue for MSDRGs relies on the correct coding, which determines the correct MSDRG, which influences the hospital payment. Some categories of hospitals are paid higher, the higher of a hospital specific rate based on their cost in a base year. And the hospitals are afforded this special payment to maintain access to services by certain Medicare beneficiary. And we see examples of this with the sole community hospitals, hospitals in remote areas that don't have other hospitals where the community at large is relying on them. We also have Medicare dependent small rural hospitals and so on. So again, these MSDRGs, they're divided into major diagnostic categories, the MDCs, and the ICD-10 principal diagnosis determines the MDC. If the service was for a procedure, the procedure determines whether it's a medical or surgical MSDRG. Coders should rely on coding clinic and coding guidelines as tools to remain current with changes to the MSDRG system. Any changes to the MSDRG system is published in the Federal Register, and these complications and comorbidities have an impact on the assignment. And coding managers and supervisors and HIM directors spend a lot of time going over these every year when the new codes come out. Another thing that we hear more about is present on admission. So if you think about it, the payer doesn't want to pay for poor quality care. So if a condition like a bed sore is present on admission, that's what we want to capture, right? Because otherwise it's assumed that the hospital is responsible for said bed sore, right? Unless the documentation and the flags are set on that. So complication is a condition that arises during the hospitalization, making it not present on admission. A comorbidity is pre-existing, making it present on admission. So when you take reimbursement, we'll talk a little bit about present on admission versus not present on admission. And we have these inpatient diagnosis indicators that are reported with each final diagnosis code. Was a condition present on admission? And we have four choices. It's either yes, no, documentation insufficient, or clinically undetermined. And it's reported for all hospital inpatient discharges for acute care facilities and other facilities as required. And again, you can look at your ICD-10-CM official guidelines, and there is a whole section on POA or present on admission. And for something to be considered POA, it must be present at the time the patient's admitted, right? And this is including conditions that develop during an outpatient encounter, such as the emergency room. Present on admissions assigned to the principal and secondary diagnosis and the external cause of injury codes. Issues with inconsistent or unclear documentation for present on admission must be resolved with the provider. So we don't just assume, we have to confirm. Any condition that's not present on admission or manifests itself during the stay is considered a hospital-acquired condition, HAC. HACs are considered preventable by CMS, so hospitals do not receive higher payment for cases categorized as hospital-acquired conditions. The case gets paid as though the secondary diagnosis is non-existent. So if some elderly, fragile person comes in and they develop, say, a bed sore, or they slip and fall and injure themselves, fracture a hip while they're in the hospital, CMS is not going to pay for that additional code that arose during that hospitalization, that fracture or the bed sore, whatever it is. And then we have more adjustments, and that's the case mix, right? So when excess readmissions are identified, we allow these hospitals to adjust their case mix. So to measure their case mix, excuse me. And what the case mix does, you can think of it as a measure of the resource consumption. And this gets back into severity of illness that's included on the case mix via the inclusion of CCs and MCCs. So when we first went on the DRG system, people would say about coding, well, as long as we focus on the principal diagnosis, and if it doesn't change hospital payment, the rest of it's really not that important. Now, with case mix index and CCs and MCCs, it does affect the payment. So it's important to code accurately, even if something's not a principal diagnosis in the hospital setting. We do have Medicare review programs that are seen under the auspices of CMS, and they review inpatient prospective payments and long-term care hospitals for payment purposes. CMS also contracts with Medicare administrative contractors, the MACs, to conduct medical and coding reviews to make sure there's not any improper overpayment. And these are some companies like Noridian, Palmetto, and a few others that you may have been familiar with. We also have quality improvement organizations, and they perform review services. They look at whether a service is necessary, if it's high quality, and they're basically protecting beneficiaries from fraud, abuse, and unnecessary, unneeded procedures and care. Quality improvement organizations review beneficiaries' appeals. They also review violations of the Emergency Transfer Act, known as EMTALA. And the Medicare administrative contractors process the claims for the beneficiaries. So they're essentially kind of like the middleman, if you will, between the hospital and CMS. They make the payments to the providers. They enroll physicians and others into Medicare fee-for-service program. They handle reimbursement issues, audit provider cost reports, and educate providers about Medicare fee-for-service billing requirements. And they actually have a free newsletter if you're interested. You can subscribe to the Medicare Learning Network. Medicare administrative contractors talk about two things. They talk about national coverage determination and local coverage determination policies to determine when an outpatient encounter is reasonable and necessary for a medical condition. And they also review documentation, medical records on certain claims for coding, billing, and medical necessity. Something you'll hear about in some of our other classes coming up is the comprehensive error rate testing. And this is basically payment error rates for acute care hospitals in accordance with the coverage, coding, and medical necessity guidelines. And these reviews are all done retrospectively. So post-payment, we go out and look at these, and then hospitals provide copies of selected records to the CERT contractor. Something somewhat new is the recovery audit contractors, or the RACs. And these are basically, you can think of them as bill collectors. They review records with corresponding Medicare claims to determine improper Medicare payments, including under and overpayments, and they correct these improper payments. And these could be such things as incorrect payment amounts that are calculated by the payment, non-covered services paid for, incorrect coding, duplicate services being billed and paid, and so on, right? So again, they get a percentage of this. So again, when you hear somebody in an HIM department talking about RAC auditors, this is what they're talking about, the recovery audit contractors. And again, there's an appeal process, right? So providers notified of a denial, and the provider has an appeal process to appeal Medicare's claim decision. There are five levels. We get into this a little bit in reimbursement, right? But you appeal to the MAC, you appeal to a qualified independent contractor, you can further appeal it to an administrative law judge, Medicare Appeals Council, and so on. And again, here's a nice slide that kind of talks a little bit about some of the things about what are we having going on with these six categories that the RAC auditors have found. And this changes a little bit, but it's usually the same six year to year. Medically unnecessary services being paid for, insufficient documentation to justify payment, underpayment due to incorrect coding, overpayment due to incorrect coding. Notice it's 5.1%, no documentation, and other reasons. But the largest one is medically unnecessary services being paid for. And again, medical necessity speaks for itself. We want to make sure that services that CMS is paying for are absolutely needed. And again, three factors to determine medical necessity: the likelihood that the healthcare service will benefit the patient, that the healthcare services and supplies are proven to be effective to diagnose, treat, cure, or relieve, and procedures are only reimbursed as a covered benefit when they're performed for something specific. And now we get into these things where it's a lot easier to do with electronic health records. Every time a test is ordered, every time a procedure is done, you actually have to, in most EHR systems, the provider has to match it to a signed symptom or diagnosis. So accurate ICD-10 coding, of course, is essential. We talked about national coverage determinations, local coverage determinations. I'm not going to belabor that. The Medicare administrative contractors develop the local coverage determinations. The national coverage determinations define medical necessity also. And the physician documentation must contain the reasons why the physician ordered a diagnostic or therapeutic service that's coded for billing. An advance beneficiary notice. This is a statement signed by the patient when they're notified by the provider prior to the service or procedure that they're doing, is that Medicare may not reimburse the provider, whereupon the patient's going to be responsible for any charges. So this is a big deal for Medicare patients. Now, something else that you'll hear some more about is the OIG work plan. And we could talk about this for hours, but basically, this is a way of refining healthcare delivery and Medicare financing. And we see such things being thrown around like the Accountable Care Organization, the Medicare Shared Savings Program, Advanced Payment ACO model, Pioneer ACO model. And basically, this is a way of coordinating care with the goal of providing better quality care and lower cost. Everybody's talking about AI. Some of you, I'm sure, are using AI. AI is playing an increasingly larger role in medical coding and reimbursement. It can be helpful. And when you see the 3M Solventum encoder, you'll get an idea of some things that AI can do. The first few models of it have been mixed, especially in the hospital setting. Places in our state of Oregon, OHSU for one, is actually using it. It seems to be much better suited for simple outpatient one diagnosis codes. It's not very effective with complex Medicare patients with multiple Medicare multiple Medicare medical problems, excuse me, or a lot of hospital procedures. Um, and again, it's one of the things that we're seeing with some of these AI generated coding systems is they have to still hire coders to go back and rework and refine and do back end edits on some of these. So again, there's no federal law about coding. It would not surprise me if some students are using AI for some of the coding. I wouldn't recommend that because the last article I read on it for outpatient, it was only 70% accurate. So again, use at your own risk. Sorry about that. And that's all I have for you on inpatient perspective coding. Come back for our next video lecture where we'll talk a little bit about HCCs, which is an entirely different model of reimbursement from Medicare Part C and of ACA plans. Anyway, that's all I have. We'll see you soon.